Hello. In this session, we look at integration of nursing services and training. The objectives of the day, we should be able to describe integration of nursing services and training. We should discuss the objectives of integration. We'll explain the professionals involved in integration. We'll describe the domains of integration. We'll describe the process of integration, and we'll discuss the common barriers of integration. Nursing education and services are sides of the same coin, both of them equally important. Therefore, is need for them to work in harmony in a concept called integration. Integration is basically linking knowledge and experience as per curricular framework of theory and practice. Theory should help nurses within the field to analyze, synthesize, organize the concept and principles of nursing, and guide excellent nursing practice. Integration is done with specific objectives. 1. We integrate to provide quality nursing care. We integrate to understand thoroughly about nursing by nurses and nurse educators. We integrate in order to provide personal and professional satisfaction in nursing care. We integrate in order to upgrade the quality of nursing and nursing profession. And we integrate in order to promote health, prevent illness by providing high quality care. Who are the professionals involved in integration? Basically, a multidisciplinary team. But specifically for nursing, when we want to integrate both theory and practice, we will involve nurse administrators, nurse supervisors, nurse educators, nursing curriculum developers, nursing curricular evaluators, nursing textbook authors, nursing faculty assigned to curriculum committee. When we think of integration, we need to think of the 3 domains of learning. We think of cognitive domain, which deals with knowledge, the affective domain, which deals with attitude, and psychomotor domain, which deals with practice. We have covered those in details previously. So what steps do we follow in integration? First, the theory we teach should be feasible, it should be applicable, and it should be realistic in terms of practice, including adapting the same to our unique settings. The nurse educator should select appropriate methods for teaching and practice. He or he should also teach the theory of procedures in classroom, then teach the practice and supervise the procedures in different settings. More often than not, we'll go into a skills lab and practice the skills the nurse educator inculcates. And then after, we need to go and follow the same students in clinical settings. Curriculum should be framed in such a way that it encourages integration, and then there should be frequent evaluation of effective integration in each particular curriculum. What are some of the methods we use for integration? Demonstration methods helps us integrate what we learned in theory and what we intend to do in practice. And then we have laboratory methods. We have ward teaching. That morning ward round, nursing ward round, is actually a learning opportunity. We have case presentations, which are done by students. We have case studies when the lecturer tells you, go and analyze this situation, see how to deal with it. You have nursing routes, we have nursing care conferences, nursing team conference, the intershift and interdepartmental conferences. You also have the shift reports, both oral and written. All those are opportunities and methods of integration. Of course, the list is not exhaustive, but those are the main ones we use. Now, facilities and equipments for integration, or which facilitate integration, are often provided by the learning institution and at times by the clinical placement institution. We should be able to provide the latest technology used in nursing, whether it is theory, whether it is ICT, whether it is equipment. We hope that we'll be able to provide the latest technology used in nursing practice. There should be adequate manpower employed in both theory or in the classroom setting and in the clinical setting. More often than not, we have the recommended ratio of 10 students to 1 staff in order to be able to evaluate the student and know whether students have been able to integrate both theory and practice. We should have facilities and equipments which are framed in a curriculum that is of international standards. So what happens at collaboration at the level of clinical practice? The clinical instructor, who ideally should be appointed either by the training institution or the clinical attachment institution, should develop the plan of care. They should be able to provide and evaluate the outcome of care. That planning is often collaborative planning. The clinical instructor plans for care of the patient with the students. The nurse specialist takes part in curriculum development. They are the people charged with the responsibility of designing the minimum requirement for any student to be declared competent. What theoretical knowledge should this student have? What practical knowledge should this student have? What attitude should we inculcate in this student? What avenues should we provide for inculcation of the attitudes? The nurse researcher in the clinical practice helps in problem solving. She or he identifies the issues, finds way of solving those issues systematically, evidence-based. They do purposive research to deal with the challenges which are identified in clinical practice. More often than not, either the clinical instructor or the researcher or the specialist will end up with dual role, that of supervisor and educator. In a nutshell, just saying collaboration should come from the school, should come from the clinical attachment area, should come from the researcher, and all take care or hold this student who needs integration of knowledge from all those aspects, and they play the role of supervisor and educator. That looks quite a beautiful ideal setting. Does it always happen? No. So what are some of the common barriers we encounter while trying to collaborate for purposes of integration? Lack of communication. Often not, there may be breakdown between the nurse educator and the clinical practitioner as well as the researcher. There has been reported lack of understanding and appreciation of what the others contribute to the team. Times, the tribute is unable to work together, either because they lack mutual trust or they lack respect or there is misconception. Often that overlap of responsibility and expertise leaves no one really responsible for specific aspect. There has been unresolved conflict between the tribute, and at times there is unwillingness to share autonomy and responsibilities. Of course, there are many other barriers to integration, including maybe the way we design curriculum, including lack of teamwork between the clinical nurse and the nurse educator. But those are issues which we should think about resolving. Most important is to ensure that whatever the student learns in class is emphasized in the clinical setting. It is improved through research and communication science. But the overall goal of all this is to ensure that we provide quality nursing care. We can read further on some of the references which we have provided. Think about how you can facilitate integration of the students who will be sent to the area you're practicing in. Look at the educator, the researcher as your friend and collaborator for the betterment of this profession. Until next time, thank you.